بسم الله الرحمن الرحيم. بالنسبة لمواضيع الاندوكرينولوجي راح نبدي بها أول موضوع راح يكون هو الثايرويد جلاند. بداية كل موضوع راح نحكي على الاناتومي والفسيولوجي، ولكن بشكل بسيط مجرد ريفيو انه راح نطب الميديسن اللي هي الديزيز والانفستيجيشن والكلينيكال فيتشر والتريتمنت مالتها. فراح نبدي ان شاء الله بالثايرويد جلاند. Disease of the thyroid gland most commonly affect the female in 5% of population. We have functional and structural disease. But first, we must know the function of the thyroid. The function of the thyroid consists of the two. The first one is regulation of the cellular differentiation, and the second is metabolism in virtually nucleated cells, all nucleated cells. So that means any disorder of the thyroid function have a diverse manifestation. Regarding the structural disease, it means just enlargement, such as a goiter, but the thyroid have a normal function. Regarding the functional anatomy and physiology and investigation راح نتكلم عليه بهاي الصورة اللي موجود هنا. أكيد كنا نعرف الثايرويد متكون من فوليكل، هذا الموجود اللي ماخذينه بالهيستولوجي، متكون من فوليكل كولويد وباور فوليكل. راح ناخذ احنا الفوليكل لأنه هو اللي راح يشكل الجزء الأساسي in the synthesis of the T3 and T4. First thing we have the thyroglobulin, which is a protein synthesized by the follicular cell and secreted to the colloid. And then iodine will bind it by tyrosine. So either we have monoiodotyrosine or diiodotyrosine. These bind in multiform and either forming T3 or T4 thyrotoxin. So the production of the T4 is higher amount than T3 in the follicular cell, but there is a synthesis of the T3 form T4 by the enzyme in the peripheral or in the heart or in the muscle or the heart muscle or kidney muscles. Like this enzyme is called monodiiodinase, and this is consisting of 85% of the T3. And then after the synthesis of the T3 and T4, they will bind to the protein, albumin, and especially the thyrotoxin binding globulin, and circulating in the blood. These are not active form and don't benefit from them, and this consists of the more than 99%. But the free T3 and T4 is less than 1%, and this is the active form we depend in screening. So this is here the function: increase metabolic rate, mimic beta blocker, beta adenotic reactions, and increase heart rate, gut motility, CNS activation, bone mineralization, cellular differentiation. The iodine need in the artery is excess of 100 microgram per day. This is maintenance for the adult. The thyroid secretes predominantly thyrotoxin T4 and T3, but the amount of the T3, approximately 85 as I mentioned, of T3 are in the blood products from the T4 by the enzyme monodiiodinase. The half-life of the T4 is more than the T3. It consists of the 1 week, and while the T3 is 80 hours. And this is a binding to the protein. 99, more than 99 will be bound and don't benefit from them, and unbound free will exert diverse metabolic action. Now regarding the control of the hormone. The control of the hormone by the hypothalamus and anterior pituitary. By the hypothalamus through the thyrotropin releasing hormone, which secrete the hypothalamus secrete thyrotropin releasing hormone to the mesh network between the hypothalamus and the anterior pituitary gland, and then stimulating the TSH, which is the thyroid stimulating hormone. These play a critical role in the negative feedback. Through what? Through T3 and T4. So when there is increase in the T3 and T4, there will be suppression of the thyroid stimulating hormone. Or when there is the increase or there is a decrease in the T3 and T4, there will be increase in the thyroid stimulating hormone. There is a balance between them through the negative feedback control. Thyroid stimulating hormone are most sensitive because it's increased critically within the increase of the T3 and T4 and decrease within the decrease of the T3 and T4. So it's most sensitive. But in pituitary disease, like adenoma, TSHoma, there will be increase in production of the TSH. And the second thing, problem is that it takes several weeks to catch up, like 2 weeks, more than 2 weeks, until increase or decrease. So it needs a time. Regarding the investigation, we first thing do the thyroid function test, like T3, T4, and TSH. Thyroid antibody for the Graves' disease, and this is also the antibody, each one for its disease. We mention it later. And the radioisotope study, and finally the aspiration and ultrasound. The classification of the thyroid disease. In hormone axis, we have a primary and secondary in each disease. Primary means the disease or the problem in the gland itself, like thyroid and thyroid gland, pituitary and pituitary gland, and so on. But secondary mean higher than the gland itself, like pituitary. So hormone excess is in Graves' disease, multinodular goiter, adenoma, subacute thyroiditis inflammation, while the secondary is TSHoma of the pituitary, and so on. In these we'll detail on later. Now, how to interpret thyroid function test? While the TSH is undetected, or mean that's low, and when you have T4 raised and T3 raised, so mostly interpretation is primary thyroid toxicosis, because they will increase in these two, in the circulatory, and decrease in this. This means the pituitary, and this means the thyroid. So when increase, it means primary الجلاند itself. يعني من يصير عندنا خلل بالتي 3 او بالتي 4 اذا ازداد، معناه اكو خلل بالجلاند اللي جاي تفرز هذا الشيء اللي هي الثايرويد، فراح نسميها primary thyroid toxicosis. بالنسبة إذا كان عندنا تي 4 والتي 3 لو اثنيناتهم مثل موجود بهاي الحالة، راح عندنا يصير secondary hypothyroidism، لأنه هنا عندنا undetected نازلة، وهنا من عندنا لو وهذا. وعلى سبيل المثال كلهم راح نيجي كل مرض نحكي عليه بالتفصيل. عندنا البروبلم presenting problem in thyroid disease. بشكل مبسط راح نقسمها إلى 2 group اعتمادا على الديزيز جروب واعتمادا على الفانكشن كلاسز. الفانكشن كلاسز يا اما هايبر هايبو جويتر سب كلينيكال هايبر سب كلينيكال هايبو. بالنسبه للديزيز عندنا اوتو اميون، عندنا ترانزيت ثايرويدايتس الانفلاميشن، وعندنا الايودين اسوشيتد ثايرويد ديزيز والسمبل اند مالتي نوديول جويتر، وعندنا الثايرويد نيوبليجيا اللي هو الكانسر.